Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIMS Kochi.
Myself, Dr. Evan, first year PG.
I'm Dr. Jarin, first year PG.
I'm Dr. Shreya, first year PG.
So today we'll have a discussion on the clinical presentation Syncope. Okay, so let's start the discussion.
Thanks. A 38-year-old male patient came to ER with a history of transient loss of consciousness. Our initial 10-second assessment, patient was conscious and oriented and talking well.
So this guy was taken to the red area.
Red area, sir.
You applied the triage, which criteria? The triage sort criteria.
Sort
Probably you would have taken him to the red area. Okay. So came with
transient loss of consciousness.
Transient loss of consciousness.
And there is some wounds over his forehead due to his fall. So,
okay, just present. We'll see.
Our initial
38 years.
38 years, male patient. Patient was conscious and oriented and talking well. And primary survey, airway was patent. There is no
conscious and oriented. Initial 10-second assessment.
Initial 10-second assessment. Talking well. Only transient loss of consciousness.
Okay.
On primary survey, airway was patent. There is no pooling of secretions. There is no any blood in oral cavity. There is no any injury over the tongue area. And breathing part, respiratory.
Airways patent means, indirectly means that there is no pooling of secretions where he is able to vocalize. No need to specifically because you already know it's airways patent. Okay, if it is not patent only, then you are supposed to mention whether there is any pooling of secretions. What makes it non-patent? Is there any foreign body or anything of that sort? Okay.
Breathing part, respiratory rate is 18 per minute, saturation 95% in room air, and bilateral equal air entry is there. Circulation part, heart rate is 70 beats per minute, BP 130/70, and all peripheral pulses are palpable, and CRT less than 3 seconds. Disability, GCS, E4, V5, M6, 15/15, pupils bilateral equally reactive to light, and GRBS is 126. Exposure part, temperature is normal.
The thing is, right now, you're bypassing all. You're not going into the specific aspects of airway patency you have checked. Then you told it's a trauma case, no? Had a injury. So you should take it as a trauma case, no? Okay. He came walking to the department or?
No, sir. The patient came in trolley.
So you don't know, till now you don't know whether the C-spine is clear or not, because it's a case of loss of consciousness with associated some facial injuries. So C-spine is clear or not, you're not sure. Airways patent, that is fine. Then C-spine has to be stabilized. Alright. So that part you have missed.
Patient is talking to and moving side to side. Head is also moving to side.
Head is moving to side to side. But then you will have to clear the cervical spine as per the trauma protocols. Okay. That we will discuss in a separate. In a trauma case, we will deal in detail about clearing the cervical spine. Right now, this is a case of syncope. So, right for that purpose, I am just ignoring the trauma aspects and all. Okay. So, airway is patent, C-spine. Presume that there is nothing wrong in the C-spine. Then B also. RR and SpO2 is grossly fine. Saturation is fine, no?
Yes, sir. 95 room air.
RR and SpO2 is fine. Then inspection, palpation, percussion, auscultation is also normal. So B is clear. Then moving on to C, the heart rate is CRT. Everything is fine. ECG.
ECG in adjuvants we take ECG.
The C aspect only will be taking, no? You will be placing a cannula, drawing blood samples, relevant blood samples for VBG. Or the GRB. Like blood will be drawn to look for GRBs, right? And then, so once you reach C, you'll be placing a cannula, right? Drawing blood samples for all the investigations, then heart rate, BP, CRT.
Monitor connecting to the cardiac monitors.
Yeah, connecting to the cardiac monitors. Then you will be auscultating for the heart sounds. Okay. Anything wrong in?
No, so just on monitor and ECG showing lead 3 T inversion is there in ECG finding. It is sometimes normal also.
Normally lead 2 only you.
As the
monitors you will get lead 2.
ECG taken that time showing lead 3 T inversions. And we taken a VBG to rule out any electrolyte imbalance. Urgent to primary survey.
Electrolyte imbalance.
And GRBS also, we checked on the GRBS checked on the disability.
Electrolyte imbalance means this is a case of fall, right?
Syncope, loss of consciousness.
Transient loss of consciousness and electrolyte imbalance, you mean to say hyponatremia?
Hyponatremia.
In VBG, okay. But the common thing for loss of consciousness is hypoglycemia. But that is
checked. 120.
Okay. All right. So nothing, as you can see, you didn't find anything significant so that you can intervene at this point. Okay. Now moving on to D.
Disability part, GCS is full.
GRBS, GCS is full. Pupils?
Bilaterally equally reacted to light 2.5 millimeter.
And he is moving all. Is he moving all the limbs? All 4 limbs. Okay. No gross sensation problems, nothing is there. Okay.
No focal neurose deficit is there.
Okay. Then? Exposure?
Exposure, temperature was normal. Any smell of any substance abuse or any smell of alcohol, nothing is there. Exposure part.
Any drugs in his pockets? Any tablets? Nothing?
Nothing, sir.
Okay. Any narcotic substances? Nothing? So primary survey is clear. Okay. Now you move on to
adjunct to primary survey.
Adjunct you have already done. What other adjunct you want?
ECG and VBG was taken. If there is any history of fever, we can have this point of care CBCRP.
For in transient loss of consciousness, your priorities will be to differentiate, to see whether the patient had first of all stabilizing the primary survey, doing the primary survey, stabilizing his vitals, and then differentiating between a seizure and a syncope. Transient loss of consciousness.
Hypoglycemia.
Okay. Seizure is most. If at all it is a seizure, you should be dealing it promptly. If it is a syncope, then we'll have to find out whether it is this syncope is because of some serious problem, because of some problem in the heart, or it could be a less because of some less serious problem such as a vasovagal syncope or something of that sort. Okay. So identifying whether it's the syncope is because of a cardiac problem is the most important thing, and to differentiate syncope from seizure. Okay. Now you can move on to the secondary survey.
In secondary survey, 38-year-old male patient is a known case of VSD. Status post VSD repair around 2015, and patient had a alleged history of inversion of left.
That is a past history. No?
Past history, sir. Known case.
Secondary survey is ample. No?
Ample, yeah.
Allergies, medications, past illness.
No any allergic to drug allergy. There is no any medical history. Events.
Medications, any?
No medical history, sir.
No medical history. Not on any medication. Past illness?
Past illness is only the VSD, and status post VSD repair was done on.
Post VSD repair.
2015.
2015. Patient is 38 years old.
30-year-old. Then events is the last meal taken on at 2 p.m.
Last meal is 2
taken
p.m.
2 p.m. And event is
fluid, drinks.
No, sir. No.
Water. When was it taken?
That is during
the 2 p.m.
Meal.
time. Okay. Then
patient had an alleged history of inversion of left foot during the that day morning. Patient is a police officer. during his activity to chase a person.
So this being a event, it's a transient loss of consciousness. You should be following that who approach. Who approach means
See,
what happened before the event, what happened during the event, what happened after the event. Okay. So who saw it? If at all some event happens, if at all somebody falls down, what all things will you ask? Where did it happen? Right? When did it happen? So where did the loss of consciousness happen?
in his bathroom. While after passing urine, he had transient loss of consciousness.
Okay. So before that, what was he doing?
Before that, patient.
Why did he go to the bathroom?
Because patient had an inversion of left foot. Patient is a police officer. During his morning jog, he had an inversion. Morning
Jogging.
jogging. He had an inversion of foot. Is there. So patient taking rest because of severe pain. Patient was taking rest in the bed.
While jogging, he had an inversion of
foot.
That should be in the road, right? It should be, or in the treadmill.
No. While jogging in the ground.
He had inversion of foot. So afterwards, what happened?
Patient takes rest for bed rest.
But he was on the ground, right?
That is morning happened. This event happening evening. Evening 4 p.m. is this transient loss of consciousness happening in the evening. From morning onwards, patient is taking rest because patient have severe
So
pain.
this is long back. This event, this jogging and all things happened in the morning. Syncope happened in the evening.
Sir.
So you can't attribute that syncope to what happened in the morning.
Due to severe pain, patient is...
Pain means pain. The maximum pain will be at the onset of...
because sir, I added this thing because due to the severe pain, patient is... While walking also, patient had severe pain. Patient went to bathroom due to the severe pain. Then he stands there. After passing urine, patient had transient loss of consciousness. So pain is also...
So while jogging, he had a inversion of foot, and afterwards, probably he walked back to his home. Like walked back.
Walked back
to his home. And then the whole day he took rest.
Bed rest.
And evening time.
After sleep, slept. He woke up for.
And something was done for that. This thing.
Nothing for done.
Anything. Cold pack or an ice pack or anything was done.
No medication was taken.
And he took rest like that. Not shown to no analgesics taken.
Nothing is
taken. And he took a nap. And by evening he woke up from sleep.
With severe pain, he is walking with his leg.
Why did he wake up from sleep? Like naturally like that, or because of the pain he woke up?
No, sir. For pass urine, he woke up.
He wanted to pass urine. And what time did he?
4 p.m.
4 p.m. He woke up from sleep to pass urine. And then he walked to the.
Walked with one leg supported. He walked to washroom. Due to severe pain, he was not able to.
Gait was antalgic, painful gait.
Painful gait.
Okay, painful gait. He walked to the
washroom.
And
after passing urine.
So probably he had some anterior talofibrillar ligament sprain or something of that. Some ligament sprain he had. A fracture is unlikely because otherwise he wouldn't have walked like that. Weight bearing will be affected. Okay. In that case, you will have to apply that Ottawa ankle rules to see whether X-ray has to be taken or not. For these Ottawa knee rules are there. Okay. See, he went to the bathroom, passed urine, and
went to bathroom and he passed urine. Then he had a transient loss of consciousness.
Was it a European closet or the other Indian closet?
European closet. He stands still and passed the urine. Then he had
while passing urine.
After passing urine, he had a blackout and giddiness and loss of consciousness. And he fell down on the bathroom.
So the bathroom was probably locked. No witnesses then. Eyewitness is not there.
No eyewitness. Not locked, sir. Only he is single person in the room. So he doesn't close the bathroom.
So he remembers that he passed urine.
Yeah, that is remembered.
And afterwards he lost consciousness. So it was not while passing urine.
Not passing urine. After completion of urination, he had the loss of consciousness. Just few minutes. Then he regained consciousness by himself.
Lost consciousness and he fell on the floor and probably sustained some injuries on the face.
There is a lacerated wound.
And afterwards he regained consciousness.
In a few seconds he regained consciousness by himself.
Okay. While sleeping, did he have any disturbing thought or anything of that sort? He took a sleep, right?
No, sir.
The thing is, in vasovagal syncope, if at all the patient, even if the patient is lying, sleeping, in his dreams and all, suppose he develops some sort of a disturbing things and all, he'll develop that vasovagal feature. He'll have the urge to defecate. He'll have the urge to urinate. He'll have the urge to vomit. And then he'll go to the bathroom. It normally happens like that. And then he go after the urge for vomiting, urination, defecation and all, he goes to the bathroom. And in the bathroom, he'll collapse. So that happens in a vasovagal. So some disturbing thoughts or anything of that sort. Fear or anything which is unpleasant things.
Unpleasant things.
Okay.
And also so some situational also, like after passing urine, after passing defecation, swallowing, coughing, laughing, also goes.
Most common things are vasovagal syncope.
Yes,
That is otherwise. Okay. So that history was not asked whether he had any
thoughts,
fearful dreams or anything of that sort. Okay. And then when he opened his eyes, he was fully conscious. Any feces on the floor? Any urination on the floor?
No.
Any other injuries apart from this thing? Any tongue bite?
No, sir.
Any bleeding?
No history of any, during the event, there is no history of palpitation, chest pain, chest discomfort, profuse sweating or nausea. There is no history of fever, loose stool or vomiting. No history of bowel and bladder incontinence. No history of
bowel and bladder, you already
normally passed. There is no history of bowel and bladder incontinence is not there. And there is no history of confusion after this event.
Okay. But that for that he will not know. Some witness should be there. So there was no witness. So whether it was a seizure, you don't know. Post-ictal confusion, we should differentiate between syncope and seizure. For that, somebody should be there. Because otherwise, when he wakes up, he'll feel everything is fine. So who saw it? Nobody. Where it happened? In the bathroom. When it happened?
After passing urine.
After passing urine at what time?
At 4
o'clock. After coming from the waking from the nap. So why does he think it happened? Why he thinks it happened? Any idea? No.
Normally he had this even similar episode in the past also.
So what happened in the past also?
Also similar episode.
After passing urine.
No, sir. In the past history, similar episode will be there. For as a police officer, while standing for a long time, he had a similar episode in the past also.
After prolonged standing?
After prolonged standing.
Because of pooling of blood in his postal hypotension, orthostatic hypotension he had. Okay. But that is different. So in that case, you mean to say that when he woke up from the sleep, probably his BP would have fallen down, postural hypotension. And more than 20 by 10 systolic BP fall or more than 10 mercury diastolic fall will cause orthostatic hypotension. Then that would have caused him to. That is one possibility.
And pain also.
Other one is vasovagal syncope. Probably he had some fearful dream. Okay. So what happened before, during the event and after the event? He doesn't remember.
No.
Afterwards he regained consciousness. What happened and all, there was no eyewitness.
You don't know where his head hit on. He doesn't know where.
Okay. And afterwards he himself got up from regained consciousness, got up from the bathroom
and informed his officers. Then they took him to here.
But by the time he informed his officers, he was completely fine, right?
Completely fine, sir.
Apart from the injuries on the face.
He himself informed them.
Oh. Okay. So after that he was able to walk and all.
The pain is there. Moving forward.
So after reaching our hospital, you told he was in a wheelchair.
Trolley.
Why was he taken into the trolley?
That's because of his pain in the lower limb. They taken.
But he was able to walk.
Yes, sir.
So ideally, this patient shouldn't be going to the red area.
Yellow area.
He should be going to the green area.
Green or yellow. Green area.
Green area. Because otherwise he was walking prior to arrival in the. Okay.
Then back to examination, sir. There is a last.
Then it's not over. History is not over. Who approach is over. Okay. Who saw it, when it happened, where it happened, why he thinks it happened, what happened before the event, during the event, after the event. Then you'll have to go system wise. The negative histories, system wise. Cardiac, CVS and RS together. Any cardiac, any problem?
No stroke,
Any chest pain?
palpitation, no
Any
stroke, chest
palpitation
pain,
before the event?
no chest discomfort, no shortness of breath, no profuse sweating.
So what all things can cause cardiac causes will cause this thing?
In cardiac
Syncope.
causes, syncope you will divide as some obstructive causes like
Some structural cause.
structural
There is
causes.
some structural cause, or there could be some rhythm
rhythm cause.
abnormalities.
Rhythm abnormality we can divide into tachycardias and bradycardias. In bradycardias, we can six sinus syndrome, then tachycardia, ventricular tachycardia, supraventricular tachycardia, WPW syndrome.
Any unstable tachyarrhythmia.
Instability.
Signs of instability, right? Syncope is a sign of.
Instability.
What are the signs of instability?
Hypotension, hypoxia, chest pain, arterial mental status,
Heart failure,
heart failure,
signs of shock.
Signs of shock, heart failure,
chest pain,
syncope,
arterial mental
chest pain.
status.
Okay. So any signs of instability, the syncope is a sign of instability. Okay. Any unstable tachyarrhythmia means may have syncope.
In
May have.
bradyarrhythmia,
Can
six
cause.
sinus syndrome, heart blocks, complete heart blocks,
Six sinus syndrome, complete heart block.
WPW syndrome, atrial
WPW syndrome, why any WPW syndrome will it have? No. It's a pre-excitation. If at all WPW syndrome causes SVT.
aberrance.
SVT. And that means tachyarrhythmia. And if this SVT causes this thing, instability, in the form of syncope. Got it, no? Okay. Then bradyarrhythmia.
Six sinus syndrome, heart blocks, complete heart blocks, third degree.
It can have syncope. Okay. What other things?
Other things, the cardiac, then structural causes, HOCM,
Then rhythm issues are not over. Brugada syndrome.
Brugada syndrome,
Brugada pattern in ECG means what?
RBBB with ST elevation in V1, V2, chest leads.
RBBB with ST elevation in V1, V2. Okay. Then what else? Long QT
Longevity.
syndromes. Okay. Then what else? What is ARVD? Arrhythmogenic right ventricular dysplasia. That also can cause this thing. Okay. But in that, what is the ECG finding in ARVD? Epsilon sign will be there. That frequently comes as question for your FRCM, RCM exams and all. One ECG will be shown with a similar kind of history will be shown, and then they'll show you a epsilon wave in the ECG, and they'll give you the various options. So one of them will be the ARVD. Okay. Then he has no history of bradycardia can be because of some drug overdose also. Beta blockers, calcium channel blockers, things like that. Okay. QT prolongation can be because tricyclic antidepressants, things can be there. But TCS and all, usually the patient will throw seizure. But in this case, there is no drug overdose. Patient was completely okay. So most likely it's a vasovagal syncope or postural hypotension, orthostatic hypotension, as per your history. So negative history pertaining to the this thing. Then structural problems. If there is some
Hypertrophic obstructive
HOCM, hypertrophic obstructive cardiomyopathy, or if there is
aortic stenosis, pulmonary stenosis, cardiopulmonary embolism.
Embolism is important, especially if the patient develops breathlessness after syncope. You should suspect the pulmonary embolism. And then ECG will be showing S1, Q3, T3. Or it could be, most common thing is sinus tachycardia. Pulmonary embolism. Maybe RVBB also will get. Okay. Then what else?
cardiac tamponade, structural loss.
Cardiac tamponade. No, it can be the pericardial effusion, cardiac tamponade, or even if the heart is having a severe LV dysfunction, also patient can develop syncope. Okay, so anything which is causing obstruction of to blood flow from the heart to the peripheries, especially to the brain, will cause syncope. Okay. Then what else?
Other classification is neurological classification.
Then other vascular causes can be there, so like
Peripheral
the
vascular
Steele syndrome and all.
So
Can cause carotid sinus hypersensitivity. Even once when I was examining a patient long back in my when I was doing my this thing was a JR. In the OPD, I just examined. I was just auscultating the heart and all, and just kept my finger like this on the carotids, and he had a syncope. Patient came absolutely normal patient. I never expected him to collapse, but afterwards he became okay. Okay, the carotid sinus hypersensitivity is one thing. Then
neurological causes, one is vasovagal. Then
negative history pertaining to CVS is clear. Respiratory system, you should know.
Breathlessness, shortness of breath.
Okay, shortness of breath is not there.
Hypovolemia, we can rule out by there is no history of any loss of blood, diarrhea, vomiting, loose stool.
That will come. First of all, CVS RS. You can complete all negative histories pertaining to CVS RS you mentioned. Then the next one is CNS, musculoskeletal examination. Any headache? CNS questions. What are questions?
Any headache, any tongue bite, any oral, any bleeding spots, any injury over the tongue area, any focal neurological deficits.
So seizure.
Seizures.
You are asking questions pertaining to seizure.
What seizures?
Any
and
headache?
Stroke also.
Any neurological deficits? Any tremors? Any seizure? Any neck pain? Okay. Even basilar artery migraine can cause syncope. Okay. Any vertebrobasilar insufficiency can cause syncope. Then musculoskeletal, there is no weakness. Okay. Even if it was a seizure, patient would have developed that TOTS paralysis.
After seizure.
If it was a TOTS paralysis, we can be sure that it was this thing. And VBG didn't show any elevated lactate.
No lactate.
For seizure, it will be elevated lactate. Lactate will be in more than 20.
2.2 lactate.
So it's not a seizure. The CVS are clear.
And there is no any bowel and bladder incontinence also, is there?
No bowel and bladder incontinence. Okay, CNS musculoskeletal clear. Then GIT, genitourinary, hypovolemia. GIT, any diarrhea, loose stools, vomiting will cause hypovolemia. Nausea. Hypovolemia can cause postural hypotension. So that is also not there. Okay. No oncological, any lumps or bumps in the blood, nothing. No oncological issues, nothing is there. Any fever?
No.
Any fever?
Just a fever.
Okay. So these are the negative histories. And then in HOP, like under presenting complaint, then you move on to the past history. Anything significant is there or not. Patient didn't have any comorbidities. He is not on any medications.
Only done is the VSD.
Then comes any family history of sudden cardiac death. Okay. That is also not there. Then social sexual. So social history, what is the policeman? And he's like physically very active person. Does he have any exertional symptoms or anything? No.
No, sir. But similar episode will be there in long standing.
Long standing. So that is there. That is one important history, postural hypotension. Then?
Then in emergency point of view, we can classify the patient into
Okay.
high risk and low
So this
risk.
is not a cardiac, like neurological problem, right? Syncope is not because of a neurological issue.
Not a cardiological.
Not a cardiology problem also. Probably vasovagal postural hypotension as per the history. Okay. Is your history over or?
Then examination part.
So, okay, now move on to the examination.
Head-to-toe examination, because trauma is also there. So head-to-toe examination, there is some lacerated wound over the left eyebrow
That
area.
we'll deal with in the trauma session. Now we'll strictly
Systematic
focus on
examination, there is patient is conscious and oriented. There is no pallor, icterus, clubbing, lymph node adenopathy. There is no pupil edema. And systematic examination, CNS.
pallor is not there. Pallor is not there.
Not there. CNS
If there is any blood loss, also patient will have syncope. Especially if the patient is a CLD. All of a sudden, patient develops syncope, and externally nothing is visible. After some time, patient will vomit blood. So that so much of blood loss, that is also a volume loss.
That
Will cause a thing. But in VBG it will be reflected. You will get a SB fall, and also the lactates will be really elevated.
Our point of care also showing any hematocrit rise also. We can.
Okay. If there is some abdominal, if it is a female patient, if it is some ectopic pregnancy, rupture or anything of that sort, also it will get a syncope. Or else if it is an abdominal aortic aneurysm rupture, will get syncope.
Pain abdomen with syncope.
Pain abdomen with some, but no GIT symptoms you told. Okay.
Systematic examination, all system within normal limits, sir. There is no any.
Basically, you should be focusing on the heart. Is there an ejection systolic murmur? Especially like HOCM and all, no? When he stands up, it will be aggravated. Ejection systolic murmur will be aggravated.
Dynamic murmur.
Then any auscultation of the
Carotid
carotids,
bruit.
any carotid bruit is there or not? That's not there. Okay. Then the other part is postural evaluation of postural hypotension. What is the lying BP? What is the standing BP? Any issue?
Nothing significant, sir. BP on supine position is 160, while standing or it is.
Standing should be measured at 1 minute after standing, and 3 minutes after standing. Lying BP, standing BP at 1 minute, and at 3 minutes. If there is more than systolic fall of more than 20 mm mercury fall in systolic BP, or more than 10 mm fall in diastolic BP, it is suggestive of postural hypotension. And then what is the treatment? Give you fluids.
And if any drugs which causing postural hypertension, we can remove that offending drugs also, or otherwise we can decrease
What drug
the
will
dose.
cause? What drug will cause?
Like alpha blockers, beta blockers, alpha blockers, tamsulosin, prazosin, beta blockers, calcium
Calcium channel
blockers,
blockers.
AC inhibitors.
But this guy is not on any
medications.
Okay. Then CVS part is clear. CNS is also clear. GIT genitory, everything is okay. ECGs. What are like other investigations? ECG.
ECG was normal. If there is any abnormality in the ECG, we will do ECG, transthoracic echo, and 24-hour Holter to pick up the change in the ECGs.
No, that is not done by emergency physician. You can do an echocardiogram for sure if you have got any suspicion, because screening echo you can do. See for the good LV function is there or not. Look at the valves. Look for any hypertrophic cardiomyopathy, HOCM, things like that. And also you can pick all the ECG abnormalities and whether to admit this case or not. This syncope. This is a case of syncope. But we haven't reached a clear diagnosis. What exactly is the cause? Could be postural hypotension, but you told on examination wise BP there was nothing like that. Vasovagal syncope is still not ruled out. That part you haven't asked. Okay. So then the question is whether this patient right now is completely okay, whether he has to be admitted and evaluated or not, or he can be disposed from the emergency department. So what is how will you decide whether this patient should be admitted or not?
Like our ED physician, we can use San Francisco risk score system. We can use
San Francisco syncope rule. Okay. So what are the parameters in that?
We can use the mnemonic is chest C4 congestive heart failure symptoms like exertional dyspnea, orthopnea, PND like symptoms, and
Congestive heart failure,
congestive
PND and orthopnea.
orthopnea, exertional dyspnea like symptoms. We can
Exertional dyspnea is not need not be congestive heart failure. Pedal edema will be there. Okay.
symptoms we can ask.
That is not there.
Not the H4 hematocrit is less than 30.
Hematocrit less than 30.
Less
So
than
hematocrit was it less than 30?
No, sir, it was normal, more than 30, 35.
Okay. So patient is in that if hematocrit is less than 30, so need not admit.
Not admit.
There is no CHF, no need not admit. So what else?
E4 ECG changes.
ECG changes, there is no ECG change, so need
only-
not admit.
S4 shortness of breath.
Shortness of breath is not there,
Not there.
so need not admit.
Then S4 systolic BP less than 90.
90.
millimeter.
What was the BP here?
100.
100. So if at all any one of this feature is there, patient will have to be admitted.
High risk patient.
For in this case, all 5 parameters which are in San Francisco Syncope rule are not there. So patient can be
Low risk
falls into the low risk category, and he can be
discharge.
discharged from the emergency department. So probably he can follow up in the cardiology department for a further detailed cardiac evaluation, which may comprise of
24-hour
echo,
Holter,
treadmill, echo, TMT, and maybe 24-hour Holter, and that they'll decide. It's not an emergency physician's role to decide on those aspects. So whether he should be admitted for further evaluation or not, that's all. Okay. So summarizing, this case is a case of transient loss of consciousness. You differentiate whether the patient is having a seizure or stabilize his vitals, do the primary surveys, differentiate the seizure from a syncope. So finally you found out it's a syncope, and then you assess in detail, use the WHO approach, evaluate in detail the history and the background history, rule out basically the most serious causes of syncope, which is usually cardiac. And once that is ruled out, you apply the do the clinical examination also, and afterwards you reach a provisional diagnosis and then apply the San Francisco Syncope rule. If all the 5 parameters are not there, patient can be safely discharged from the ED. Okay, that is the plan. Any other things to be discussed? Okay, thank you.